Hello there, listeners. It's Susie New from the Australian Society of Anaesthetists, and thank you for listening to our podcast. It's called Australian Anaesthesia, and it's where we talk about all things relevant to anaesthesia in Australia, and in this case, something of global importance. Before I introduce my guest today, Dr Ethan Fitzclarence, I want to welcome any new listeners out there who have found your way here by following the QR code in the March 2026 edition of Australian Anaesthetist. Thank you for visiting, and I hope that you like what you're about to listen to. For our subscribers and regular listeners, I want to explain what is going on. Australian Anaesthetist is a quarterly coffee table style magazine that is produced by the ASA. If you're an ASA member, then you should be receiving it in the mail unless you've opted for the digital only version. The theme for the March 2026 edition of Australian Anaesthetist is advocacy. And I couldn't think of a better addition to try out an idea that was initiated by Dr Nathan Chin, an ASA member and trainee in New South Wales. His idea, and I hope that I have paraphrased this right, is to have an eye-catching image, something that will hopefully grab your attention, pique your curiosity, and not much of an explainer to go with it. It's very visual. And on that image, is a QR code. Follow that QR code and you will arrive at some useful resources such as a podcast, a webpage, maybe an article. We'll look at what that develops into over time. So if you're a regular listener, thank you, by the way, for subscribing or following the podcast, then you probably come to this podcast through your regular podcast app and you may not have seen the image. If you haven't, then I encourage you to have a look. The Australian Anaesthetist magazine is available for free on the ASA website, asa.org.au. The image is fantastic, really eye-catching, and was developed by Dr Chin, who has some serious graphic design talent. We've also tried to make it so that the page can be cut out and used as a poster for you to display around your operating theatres and hospitals. At the time of recording this podcast, I haven't yet seen the finished version. I'm really excited to see how it all looks when it comes together. It's still very much in the early experimental phases, so if you have any feedback, let me know. Send me an email, podcast@asa.org.au. And thank you once again, Dr Nathan Chin, for getting this initiative off the ground. Another trainee who is punching above their weight is our guest today, Dr Ethan Fitzclarence. Dr Fitzclarence is from Perth in Western Australia, and we are discussing the work that he did on measuring nitrous oxide wastage from hospitals. And for this, he won the Nerida Dilworth Prize. So congratulations. If you're like me and many other anaesthetists, then you probably value efficiency. So the idea of wasting between 50 to 100% of a medication just seems abhorrent. It's a lot of money. It's a lot of logistics to restock it, to organise it. So there's all of that. But then when we're also talking about a gas that lingers in the atmosphere, causing negative climate effects, something that will impact our planet and every living being on it, then I start to wonder how long we can go on tolerating this waste. So I'm hoping our chat perhaps inspires you to look at how nitrous is delivered in your hospitals, in your operating theatres, and perhaps even try to do something about it. Whether it's measuring nitrous oxide wastage or just saying no to pipeline nitrous and getting the wheels in motion to decommission it. Dr Fitzclarence shares some more tips and some other ways we can get others involved in looking at this issue. And as you'll hear, Dr Fitzclarence and I are not the only ones who think that this is a good idea. All right, let's get into it. So we are chatting because you won the Nerida Dilworth Prize. Congratulations, first of all.
Yeah, thank you.
Do you know who Nerida Dilworth was?
I've learned a lot more about her since having won the prize. I didn't know who she was beforehand, as her career pathway didn't intersect with mine. But yeah, it was interesting to learn a bit more about her as part of the process.
What have you learnt about her?
So I learned essentially that she was a bit of a pioneer of anaesthesia in WA, and particularly anaesthesia for women in WA and research. She did a lot of training in Western Australia and left behind this bursary to fund a registrar prize every year for research and development, significant contributions to the anaesthetic profession.
I didn't realise the prize came with money. Wow, congratulations.
It's not a large amount of money, but something to recognise her contribution, yeah.
Fantastic. Love it when people leave a legacy like that. And the research that you won the prize for was to do with detection and quantification of nitrous oxide leakage. Is that right?
Yeah, correct. So it was spearheaded by my supervisor, Dr Chris Mitchell, who's quite big in the environmental space, and we worked at a number of hospitals across the state to both detect and quantify leaks.
So tell me how you went about doing that.
We used a modified technique that was originally developed by a team in the anaesthetic department at the Alfred Hospital in Melbourne. And that technique has actually since started to develop or progress into the Australian government approved methods of detection of leaks. And so what it involves is a modified weighing method, essentially, by which we get the nitrous oxide at the manifold, we get the cylinder at the manifold, and we place a sensitive scale underneath that and weigh that cylinder at intervals during periods of zero usage, ideally. So we had to liaise with different departments in the hospital to make sure that no one was using any nitrous oxide during that time. And by weighing the cylinder over a period of time, we could see any drop in the weight of the cylinder and therefore use that to calculate how much was leaking out through the system.
So you had a special device to weigh nitrous cylinders?
Yeah. So the original method that they used at the Alfred, they used a full G-size cylinder that was plugged into the manifold. They used a scale that was sensitive to 10 grams. We modified that slightly. We modified that to just periods of zero usage. So we liaised with all of the departments in the hospital to make sure that no one was using any. We supplied C-sized cylinders to areas like the labour suite. And we used a much more sensitive scale. Rather than taking measurements every 5 hours of the weight, we were taking measurements every 5 minutes. It was sensitive to 2 grams, calculated over a period of 3 to 6 hours in most cases. And by doing that, we can rule out any usage, and you can actually see if anyone used any nitrous because there's a sudden drop in the cylinder weight because it's so sensitive. And so you can remove those periods to make it much more accurate. But you can also eliminate that problem by having a much shorter period of testing. And we just plugged a cylinder into the manifold directly. Although there was one hospital where that wasn't possible and we had to use the same method that they used at the Alfred, and we just had a 24-hour period where they just didn't use any for that period.
So I suppose that's much more efficient than the Alfred technique where they were doing it over 18 days. You're only doing it over a few hours.
Yeah, I guess the downside is that you get a shorter period of data collection, and so you potentially are biased from that perspective. But we hoped that by using a much more sensitive scale, we could effectively remove that problem.
And I can imagine, so you're sort of crawling around the basements, the back ends of the hospitals trying to find their gas manifolds?
Yeah, so a lot of liaising with the engineering team. Thankfully, what I found, crawling is probably how to say this, it's probably over-glorifies what we were doing, because what I found in this process was that the basements often have more space than anywhere else in the hospital. Massive high ceilings and lots of space for equipment and stuff to move through, so we weren't limited for space at any point. We went to the manifold areas sort of directed by the engineers at each hospital, and we liaised with them to make sure that we were disconnecting appropriately, reconnecting with the C cylinder, and making sure that there was always a constant gas supply so we weren't putting any patients at harm at any point. I should mention that at any stage, should any patient require nitrous oxide in the hospital at any point, there is always a cylinder plugged in. They're always connected to the manifold. There's no point at which patient safety was neglected in any way.
And I'm just trying to understand, so the manifold has G-size cylinders and then you were disconnecting them and reconnecting a C-size?
It depends on the hospital. So like Perth Children's Hospital, for instance, has F8 packs where there's 8 G cylinders connected to one outlet, and that's connected to the manifold. But a lot of the more modern manifolds have a single hose coming out of the side of them, and you can connect a single cylinder into that, and that's what we did in most cases. Although there are some where you have to just directly disconnect the cylinder that's connected, and it has a copper coil attached, and you have to basically attach the cylinder that you're replacing the manifold cylinder with directly to that. And if you're putting a C-size cylinder there, you have to make sure it's the appropriate height and you're not putting too much tension on the copper spring that can then affect the weight.
And the C-size cylinder, what was the role of that?
So the reason for that is that it's a much smaller cylinder. And so we could put it on a smaller set of scales that was sensitive to a smaller weight. So rather than having a scale that's sensitive to 10 grams and measuring over a longer period of time, We used a scale sensitive to 2 grams and used a much shorter period of time.
I see. So you're taking off the G size, you're putting on the C size cylinder, a smaller cylinder, and then you're applying the scales and then looking for the leak from the C size cylinder.
Yeah, correct.
So it's like your testing cylinder.
Yeah.
Gotcha. And so that identifies that there is a leak or not. Does it then help you identify where that leak might be coming from?
No, so there's no isolation from that initial round of testing. And so it's purely detection of leak and quantification. So we can find out that there is a leak in the system and we can quantify the volume over it. We can annualize it essentially. However, it doesn't help us isolate it. But what this led to at Armidale Hospital, for instance, was that it led to a period of further testing. And so what happened in that particular instance, a couple of years ago, I was rostered on shift on New Year's Day. There was nothing happening in theatres whatsoever. And so I used that period, having gained prior approval, to basically go around all of the operating theatres and turn off the nitrous valves to the theatres whilst having the anaesthetic machines connected. You would know that if you look at your anaesthetic machine, it has a nitrous pressure listed there. And so what we did was, once you switch off the valve in the theatre itself, you can then watch that pressure on the machine. And if there's any leak between the valve and the machine, that pressure will drop. And so we did a period of testing in the operating theatres, and we found that there are 7 theatres at Armidale Hospital. 5 of them were leaking to the point where they set off the low pressure alarms within about 30 minutes. There were 2 theatres that were leaking, but to a much lower rate. What that then led to was us being able to advocate with the engineering department to say, look, we know that we have a significant volume of leak within the hospital because we've proved that already. What we didn't have at that time when I did this testing was we didn't know the volume of the pipes between the valves where I had switched it off and the anaesthetic machines, because we didn't have those maps. But that could be calculated, and we could calculate how much each theatre was contributing to the leak if we had that information. But essentially we were able to take the information to engineering and say, we've identified that these 5 theatres have significant leaks. That led them to then going in and being able to do more maintenance in those areas, replacing O-rings, etc., that then is designed to reduce the leaks.
How do you know it's not a leak on the anaesthetic machine side versus the pipeline side?
We don't know where it is. We know that it's between that valve and the anaesthetic machine somewhere. But it doesn't necessarily matter whether it's the connection to the anaesthetic machine or the wall outlet, because it's leaking from somewhere. And then we essentially provided that information to the engineering department to say, are you able to do what you can to rectify that?
How many hospitals did you visit?
So we went to Armidale Hospital, was our first one. We went to Albany Hospital, which is down in the southwest of WA. And we did the Perth Children's Hospital, which is our newest hospital in the state. Dr Chris Mitchell, who I mentioned earlier, had already done a similar test at Charles Gardner Hospital, and that had led to them actually completely disconnecting from the manifold altogether, essentially, and shutting down the entire pipeline nitrous system. They had identified a very, very large leak in their system, and it sort of said, well, we don't have OBS or PEDS, so there's really limited value in having a pipeline system. And we've been liaising with the King Edward Hospital as well, the Women's and Children's Hospital over here, to try and do the testing there.
I know Albany is quite far from Perth, so you've travelled a lot, you've had to do all the liaison with the engineers. What motivated you to take on this project? It's an incredible amount of work.
There were a few things. One was that we have to do an audit for training, and so I was looking for something in that. And then I was working at Charles Gardner at the time and having an interest in green theatres and environmental sustainability. I got chatting to Chris Mitchell about different options and projects that he was running as his environmental lead. And this was a project that he had been toying with, and we were able to work together to really take it on. Armidale Hospital was a good starting point because that was the hospital that I had been rotated to at the next phase of my training. And Albany actually was convenient for me in some ways because whilst it is a fair way away, being about a 4-hour drive from Perth, Chris Mitchell had already been liaising with that team there because they had expressed an interest from the air engineering side and the faculty management side, which was useful. And I had an uncle who lived in the area that I was planning to visit. So I turned a day trip into a multi-day trip and went down and plugged it in, hung out with my uncle for a bit and went back the next day and disconnected it all.
Awesome. You've got to make it work.
With PCH, I happened to be rotated there and I liaised with the team there and we were able to make it happen there. They were really great to work with at PCH, actually, from both the anaesthetic department and the engineering side. They gave me a full map of the nitrous oxide system that showed there are nitrous outlets on the helipad on the roof for all the times that you might need it up there. And and they have nitrous oxide plumbed into basically every room, every ward in the hospital. And it's little wonder that this brand new hospital has one of the biggest leaks that we found.
And do you need nitrous going into every room?
No. And that was sort of what we pointed out to them, is that you've created a monster in some ways. It's a beautiful new hospital. It has facility for everything, but it's got so many unnecessary connections, and every one of them is a potential source of leak.
Yes, and potential source of abuse as well. It could be diverted. What was it like working with engineers? Have you worked with engineers before?
My brother's an engineer, so I had a little bit of exposure. For the most part, it's been fine. There has been some pushback at some hospitals where we've come in and said we'd like to do this testing, and the response has been, oh, well, we've done our mandatory checks. There's nothing to test. The challenge there is that the engineers are held to a certain standard, and we recognise that that's the standard that they are expected to meet. The reason that we implemented this testing is because there was a concern that that standard is inadequate to actually detect a leak in most cases. And the feeling was that it probably was doing an insufficient job of identifying the presence of any nitrous leaks, and that we were leaking despite those tests. So, for instance, Charles Gardner, I mentioned, they detected a large leak there. That wasn't through their mandatory testing. It was purely through the recognition that they were purchasing a lot more nitrous than they should be for a hospital that doesn't have obstetrics or pediatrics. And then subsequently trying to delve further into where this could be going. And they identified essentially a hole in one of their pipelines that was just pouring out this nitrous oxide.
And that had passed their standard engineering checks.
Yeah.
So it sounds like the standard's not good enough.
That was the concern. Part of their standard is they do a pressure testing system where they load the system under pressure, but there has to be a massive leak for the pressure to drop significantly under their pressure testing in order to detect it. And then they do soapy water tests where they put some soapy water over each valve and see if anything bubbles up. But once again, there has to be a fairly significant leak to see a bubble in the short space of time that someone's looking at it. And so it wasn't necessarily sensitive enough to detect significant leaks.
Should we be looking to change the standards for testing?
I guess that would be the ideal. And it's interesting as there's been some development in the different approved methods of detecting leaks. Certainly the modified Alfred method is one of those that's now approved by the Australian government, and in a conjoined statement with the Centre for Disease Control, they have developed a practical guide over the last 12 months for detecting and reducing nitrous oxide leaks. They provide 4 different methods that they suggest, and this is one of them.
Great advocacy there. Well done.
I don't think I could take credit for it, but it's nice to contribute to the research in a little bit, and hopefully it makes a difference over the long term. What we've seen in other areas in the state that we haven't done this testing, or they've done their own local testing that's similar, they've recognised the significant leaks that we found in the hospitals that have been tested, and then they've moved towards a transition away from the manifold systems and pipeline systems altogether, even without the formal testing being done necessarily. So Fremantle Hospital in Perth recently moved away from the pipeline system to a bottled system just in the last couple of months. And I know Royal Perth is transitioning a similar way.
Well, that's an even better solution, isn't it? Because from what I hear, it's anywhere from 65 to 95% of nitrous is being leaked out of pipelines in hospitals.
Yeah, it's pretty crazy.
Staggering waste.
And we thankfully didn't find any leaks quite that large, although Perth Children's, our newest hospital, was probably the largest percentage at 45 to 55% of the nitrous being leaked out. Although I mentioned there's so many outlets, it's no wonder that there's such large proportions being leaked, even though it is our newest hospital. But certainly the UK, where they did this testing, it was pretty standard to find between 80 to 90% of leak. And one hospital was as high as 99.8% of all purchased nitrous just leaking.
That's ridiculous. Talk about wastage in healthcare.
Yeah, and completely agree. It's much better to just not have the pipeline system in the first place if it's avoidable. Obviously, areas like the Lade Suite still use it a lot. The Royal College of Anaesthetists in the UK has come out in recent times and released a consensus statement alongside the Obstetric Anaesthetists Association and the Paediatric Anaesthetists Association to basically suggest that new hospitals are developed without these pipeline systems, certainly to operating theatres, and that there's more of a reliance on C-size cylinders in the immediate period of requirement, excluding areas like labour suite where it is used to a greater degree at this stage, but essentially trying to transition away from having broad pipeline access to entire hospitals. We've been trying to advocate for that for one of our new hospitals being built in Perth at the moment.
Well, I hope that gets over the line. I know my hospital in Melbourne, we've discussed that as well. So I think the word is out, and hopefully this podcast will help get the word out even further.
Excellent.
If someone's interested in looking at whether they've got leaks in their nitrous in their hospital, have you got any tips there?
Yeah, for sure. So certainly it can be done reasonably efficiently if you're using a much shorter time interval. And by having that smaller cylinder with a more sensitive set of scales, it facilitates less time on the ground in order to do this. I was fortunate to have Chris Mitchell in my corner, who had developed a computer system to automatically record the readings from the scales. But a similar system could be used if you're able to connect your scales directly to a computer that creates an Excel spreadsheet that then can produce a graph over time, then that's the most efficient way. Otherwise, I know that others have used a video camera just recording the scales over the time interval. And if you're only doing that over a period of, say, 3 to 4 hours, then that doesn't take up an excessive amount of time to monitor. Obviously, the longer it takes you to observe, then the more video you have to scroll through and the more data entry is required. But essentially, what I'd suggest is just touching base with your anaesthetic supervisors and team early, and then liaising between them and your head of department and the engineering team and saying, look, these are our concerns. We recognise that this is a significant environmental burden. We'd like to do some further testing to identify the presence of leaks that may have been missed by the standard assessment. Can we liaise with you in terms of gaining access to do that?
Where did you get the scales from? They sound very particular. And I love the idea that scales can plug into your computer and just spit out the data.
Yeah, that was Chris Mitchell's sort of baby. He went and bought both a set of scales and a computer specifically for this project out of his own personal funds, just because he was quite passionate about it. And it was really good for me to have a supervisor who was so invested and on board. And he set those up, connected them together, and they're available in WA for any hospital that wants to do this testing. And he will provide those free of charge with a small amount of training to make sure that you're proficient in using them. That's been an option over here, but a similar system could be done anywhere. The computer, I think, was just a standard PC, and then a set of scales is basically just having a set of scales that has an outlet connection that can be plugged into a computer.
And then you had to get also the C-size cylinder. So how did you go about getting that?
Yeah, so the Charles Gardner Hospital had already been transitioning away from using the pipeline system. At Perth Children's Hospital, it's literally across the road from Charles Gardner Hospital. So we borrowed their C-size cylinder from their theatre backup, having liaised with the theatre team there and saying we can bring it straight back within minutes if we need to. In other hospitals, we had to order in the C-size cylinder ahead of time and basically pay a small rental fee to BOC for facilitating that, and then it gets returned at the end. Probably the biggest challenge from all of that perspective was not so much getting the C-size cylinder for the actual weighing, but getting a number of C-size cylinders for distribution around areas like the labour suite in order to have ongoing supply to patients during a zero usage period on the manifold itself, and not so much the supply of the cylinders because they're reasonably cheap and easy to access, but the connections from the cylinders to the patient supply. The regulators are quite expensive, and so that was a challenge.
Apart from Perth Children's and Charlie's, which were across the road, I'm assuming you need to get the C-size cylinders at each hospital because you can't really drive around with the C-size cylinder in the back of the car.
You shouldn't, and I wouldn't advocate that.
Neither would I. I'd say organise your C-size cylinders at your different sites, get the right scales.
Yeah. Getting the regulators is probably the most difficult part of the system to make sure that there's supply to the floor where it's needed. That's not an issue in theatre because we just connect straight into our anaesthetic machine, but for the portable outlets for labour suite, etc., that's been the challenge.
All right, that's a good little checklist of things that people might need to do if they're contemplating doing this. So liaise with engineers, get some C-size cylinders, get some regulators, look at where you might need to get some extra C-size cylinders if you're doing obstetrics in particular. Think about getting the right scales, hopefully ones that plug into your computer so it automates the data upload to a spreadsheet. I suppose the other option is just to advocate for your hospital to move away from pipeline supply of nitrous and go to cylinders.
This is already being the suggested pathway by a number of international organisations and probably the way of our future. We can do the testing and confirm that there is a leak, or we could just jump to the solution. And if that's the easier pathway, then great, go for it.
Did you need to seek ethics approval?
We had to seek approval from each hospital, but each hospital was a little bit different as to whether they wanted us to get ethics approval or not. The way it works in WA is there is an approval board for any audit that occurs. Some of them were saying because it directly involves patient care in terms of adjusting or changing the way their nitrous is supplied, ethics approval was required. But we were able to argue in most cases that it was unnecessary because we were still supplying the same medication to the patients in a similar timely manner. We weren't really changing their care in any way besides having nitrous from a cylinder rather than a manifold. So it hasn't been a problem thus far.
Have you published this work anywhere?
So I presented it at the Euro Anesthesia Conference back in 2023, I think it was, and they published the abstract. And I agreed to that being the limitation of the publication. I have not gone on to publish it anywhere, but partially because the Alfred team published in the Australasian Anaesthesia on their system, and I felt that we were really borrowing their technique anyway, so it wasn't necessarily for me to steal away from them. As I said, it's just another piece of evidence in our local sphere at least. I'm certainly more than happy to provide the data that we found to anyone who's interested.
Is there anything else that you want to say either about Nitrous doing this work, winning the Nerida Dilworth Prize?
The only other things that part of our challenge in getting this through engineering and the obstetric teams has just been the recognition of what a problem this is. And so I think education is probably a good first place to start as well. We were liaising with the midwife team at the Women's and Children's Hospital here in Perth, and there were a number of midwives, in fact, the vast majority of them that I had spoken to had no concept that there was any significant side effects of nitrous oxide. And so there was no real impetus or drive from their perspective to help facilitate. When we started talking about teratogenicity and problems with organogenesis and the risk even to the midwives themselves with secondhand nitrous, like midwives that were pregnant being exposed to large volumes of nitrous over their entire working shifts whilst early in pregnancy and working with these labouring women, that was something that they'd never heard of before. And so they had no real concept of the concern. And so there's the local environmental effects from that perspective. And then the broader environmental effects weren't fully recognised as well. In Albany, there was a bit of drive on the hospital management side to help facilitate this. And that was driven by an understanding from their team of what a problem this was to both the local and broader environment. And that made it much easier to facilitate. I think probably putting in those education systems in the first place will hopefully help break down some of those barriers to implementing the project or a similar project, and also help provide a bit of impetus to create change once problems are identified.
That's a really good point, because some people will look at this as an environmental issue. Some people will look at it as it's a finance issue. It's just a lot of money that's being distributed to the atmosphere. But I love that really it's about the patient and the risks to them and our colleagues, our healthcare worker staff.
Yeah, absolutely.
Well, look, thank you for your time this morning. It's been really fascinating and I've learnt a lot from this conversation. I really hope more people take up the cause and really look at the nitrous use in their hospitals and that we do see less wastage of it.
Yeah, absolutely.
Thank you so much for your time.
Pleasure. Thank you, Susie. It's been wonderful to chat.
Well, I hope you enjoyed listening to our conversation and agree that there is some great talent coming through the training pipeline. I hope we continue to support it and that it grows and that the future keeps looking brighter and brighter. As Ethan mentions, anaesthetists around the globe are considering this issue. There's been statements from the anaesthesia societies in the UK, the US, and even the World Health Organization has come out recommending cylinders over piped nitrous. You can read more about this in a joint statement that was published by the ASA in conjunction with the College and the New Zealand Society on decommissioning nitrous medical pipeline systems. Ethan mentioned Dr Chris Mitchell, who supervised this audit and has generously made this equipment available to anyone in Perth. If you'd like to read about another audit done by Dr Mitchell, then I suggest you read an article that he co-authored in the September 2022 edition of Australian Anaesthetist. In fact, the theme for that whole magazine is environmental sustainability, and it's available for free on the ASA website. And finally, if you're a trainee looking to do an audit, then consider joining TRASH. That's spelled TRA2SH. Or in NATO speak, Tango Romeo Alpha number 2 Sierra Hotel. And it stands for Trainee-Led Research and Audit in Anaesthesia for Sustainable Healthcare. You can learn more about TRASH in episode 69, where I talk with Dr Jess Davies, one of the co-founders of TRASH. Of course, I'll put a link to these 3 resources in the show notes. And finally, congratulations and welcome to the trainees who are starting this year. I hope you really enjoy taking your first steps into anaesthesia, into what I consider to be a really marvellous profession. And I hope as you get through the exam hurdle and look at what the specialty is like and what the specialty does, that you, like Nathan, like Ethan, bring your bright ideas, bring your enthusiasm. I hope you have long, fruitful careers and that you keep inviting the ASA to support you, represent you and be involved. And as always, I hope you, no matter what stage of your career, that you and your patients are staying safe and well out there.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists, with many thanks to host and editor Dr Susie New, with music by Soda Lime Music, sound and engineering by Bearview, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.